welcome to the Westin MCAT podcast with your host, Ahmed and
Jayden Garcia.
Hello, everyone, and welcome back to another episode of the Westin MCAT podcast with Ahmed and Jayden. Today, we're going to be looking at the respiratory system. But before we get into that, hopefully everyone's doing well. Jayden, long day at the residency today. How did that go?
It was really good, Ahmed. So I think I mentioned this on last episode. I'm in the surgical ICU right now. So I'm taking care of patients who have been operated on, had some really big surgeries that require intensive care. And any surgeon who's in training will spend a significant amount of time in that unit. And I'm really excited today to share, how the topic of today really plays into almost everything I was doing on my last 28-hour shift. So I'm a little tired today, but also enthused by what we're going to discuss.
Enthusiasm trumps all. So glad you're here, Jayden. And
Thanks,
so on the note of the respiratory system, let's sort of walk through what it does and how air kind of moves, and then we can get into more specific applications. But I think obviously we know that the respiratory system brings in oxygen. That I think is a really well-known function of the system. But there's also, other aspects to, acid-base balance, even just having a different set of, infrastructure so that digestion can be fully separated. For anyone who's ever, had food or water go down the wrong pipe, the importance of having two different pathways there. But I guess let's start with that. Where does air go? What happens to air as we breathe?
Yeah, so air has really two initial opportunities or options to flow if we're talking about inward flow. It can go through the nose, through the nasal cavity, or it can go through the mouth. Either way, both of those pathways are going to adjoin in the oropharynx, which sits, it's a fancy term for throat. In the throat, we have two different tubes that air can flow. Hopefully it doesn't go down the esophagus, but in reality, when we breathe, some portion of air does get down in our esophagus, and that's why we have to belch on occasion. That's just the way it goes. So some portion of air does escape down the esophagus into the stomach. However, the target is to go through the vocal cords, which sits just anterior in front of that esophagus. As the air goes down through the vocal cords, you'll then hit the trachea. The trachea is the windpipe, the main vessel of air that is the train tracks to the lungs. And once the air has gone through the entire trachea, which part of the trachea is above the clavicles, which is kind of my domain, but part of the trachea actually dives deep into the chest. And that's called the intrathoracic trachea. At that point, the trachea is going to divide into two bronchi. We call them primary bronchi or main stem bronchi, the right and the left. Anatomically, they're different, and really it's important to note the difference between the two. The right main stem is very much a direct pathway straight down, whereas the left main stem kind of moves out toward the left lung a little bit earlier at more of an acute angle. The reason that's so relevant is when I get called to an airway for a kid who has maybe aspirated or choked on some button battery or a coin or you name it, almost always it's going to be found in the right main stem because gravity is going to pull it in that straightforward direction. It does happen in the left, but I think that's a relevant piece to include when we're thinking about the anatomy of the bronchi. So once we're at the level of the bronchi, there's many other branches to this tree. I think pertinent to our podcast, there's primary, secondary, and tertiary bronchi as you branch out toward the lungs. And the distal target of air, the whole point that we go through this process of breathing, so that air can end up in the alveoli. The alveoli are a sac that has a bunch of lung cells, pneumocytes, that participate in gas exchange. And if that process isn't happening, the patient is going to desaturate. They're not going to have oxygen appropriately attached to hemoglobin and carbon dioxide appropriately expelled from the system, which leads us to the exact same pathway out of the lungs. So the main purpose of oxygenation is to dump O2 from the air into our alveoli so they can cross a membrane where there are capillaries, really small blood vessels just right adjacent to those alveoli. And at the same time, the capillaries are going to trade CO2 so that CO2 can exit the lungs through our trachea, through the vocal cords, through the oropharynx, and either through the mouth or through the nasal cavity.
Right. And I think what's interesting there for me anyway, like I always kind of think of not always, but I tend to think a lot of the physics behind it. And I mentioned in a previous episode, I was one of the goofballs that actually kind of enjoyed physics. But, one of the hardest things in physics for me to understand was the role pressure played in bringing air in and out. And it's really like, I think one of the simplest ways to think about inhalation specifically is your body just kind of acts like a vacuum. Instead of I guess I always had this image in my head that we're just moving, we're moving something physical into our body, whereas really it's more of a suction effect. And basically the way that works is, from our understanding of ideal gas law, if something expands, the pressure, if a cavity expands, the pressure inside it drops. And so basically what ends up happening is we have a series of muscles that contract to expand that thoracic cavity to lower the pressure. And that pressure drops below atmospheric pressure. And so what ends up happening is there's a pressure gradient from the outside into our mouth and into our lungs ultimately. And so those two main muscles being the diaphragm at the bottom of that cavity and the external obliques and the rib cage to elevate the rib cage upward. And I think understanding that and how there's that suction effect is important. And it also explains sort of the anatomy of that cavity, how the diaphragm kind of looks like an umbrella almost. And so when it contracts, it flattens, which increases the space above it in that cavity. And then that's why inhalation is active. It takes effort. Whereas exhalation can be passive in that there's an elastic recoil of those muscles that compresses the cavity, increases the pressure, and then air subsequently flows out. Now, exhalation can also be forced. You can just, right, you can really put effort into it. But one of the not weird things, but one of the really cool things, I guess, about the respiratory system is some of these things you can sort of figure out just kind of while you're sitting there. If you I remember, I think it was in either undergrad or late in high school, but I remember getting a question about which of the following is forced versus passive. It was inhalation, exhalation, a couple other things. And I kid you not, I was sitting there on the test and I was just breathing very emphatically just to figure out the answer. But I think that understanding of the anatomy and where air goes is key. And then you kind of touched on it there, Jayden. It gets to where it's going. Now what?
Right. Now what? Right. Because if we go through this whole process and we can't actually execute the gas exchange, we really haven't done anything.
Right.
And that's what correlates to a lot of my patients right now in the ICU. Because for the most part, patients can have trouble with this process we're talking about. They can have difficulty, and especially in my realm, with getting air from the nose or to the mouth, or from the mouth to those lungs. They can have an obstruction. They can have a spasm, right? Of the bronchi that we discussed have muscles surrounding them. So patients who are asthmatic or whatever, they really clamp down and can make it very difficult to get air from point A to point B. Generally, if we absolutely have to, we could mechanically ventilate a patient and kind of take over that process. I can get air from point A to point B, but to your point, Ahmed, like, what happens if we can't actually exchange gas? And so I have a patient right now who's been in my ICU for a month. She had influenza type B. She has no other comorbidities, and she has been sedated and mechanically ventilated for a month because she has overwhelming ARDS, which is acute respiratory distress syndrome. It's the same condition that people who die from COVID end up undergoing. The virus, influenza or COVID, causes an extreme inflammatory response in the lungs. And essentially, the lungs fill with water. The outsides of those alveoli fill with water, right? Histamine is being released everywhere. So the blood vessels are dilating. And it's really, really hard to control because we can put them on a ventilator and get the air near the alveoli, but they can't diffuse the gas. And so this lady's really sick. It's a very high mortality condition. And we're constantly thinking about this process of oxygenation for her. So as we mentioned, O2, oxygen, ideally will have a nice dry alveolus whereby it can passively diffuse, not actively, passively diffuse from the alveolus into the capillary. It should link up with a hemoglobin molecule where it will change its configuration and bind so that
And
hopefully it can be taken to further tissues. What was that, Ahmed?
and Jane, just to elaborate for the viewers, why
Yeah.
specifically does the alveolus need to be dry?
Yeah. So water, pus, anything acts as a significant barrier to diffusion.
Right.
So there's a very important law that MCAT test takers need to be very aware of, and that is the Henry's gas law or the Henry's law, essentially telling us like the more partial pressure we can get into a given space, the more diffusion that will take place into liquid.
Right.
If I fill your lungs full of water, pus, etc., that's just more of a barrier that oxygen has to go through before it can get to the bloodstream, making it very difficult to oxygenate a patient.
And so it's not just it's not just a physical layer in terms of thickening that alveolar surface, but it's also a diffusive barrier in the sense that the PO2 has gone down.
Exactly.
And so I think that's also important to understand is like structure and function, especially in the lungs, but throughout the body and even at the level of proteins are extremely intricately intertwined. And so the thinness of the alveolus and the alveolar membrane is what facilitates this diffusion of gas exchange or that facilitates this diffusion of oxygen and carbon dioxide, excuse me. And any slight thickening of that can be catastrophic.
Yeah,
But
I mean, this is where understanding normal physiology is so crucial to understanding pathophysiology. You eloquently highlighted that the alveolus is nice and thin. But what about these patients who have pulmonary fibrosis or
right,
thickening of their lungs? You can imagine diffusion becomes quite difficult, as you brought up. And these patients also can be hypoxemic or have low oxygen levels because they just really struggle to get that oxygen through such a thick barrier.
right. And it's always mind-blowing to me how just a subtle change to the respiratory system can have such widespread effects simply just because of the desaturation of the blood as a result. Like not to throw arbitrary numbers out there, but just a minor thickening of the alveolar membranes or a minor constriction of a bronchus can be extremely significant. And I think that kind of leads into the next point, which is how does oxygen ultimately contribute from or move from the lungs to the rest of the body? And you touched on hemoglobin there, but I guess the physics behind it, the pressure, like how do we actually get saturated? We mentioned desaturation, but what does saturation mean?
Right. So thinking back to this partial pressure idea, the partial pressure of oxygen in the normal air we breathe is like 0.2. It's roughly 20% of everything out. Most of the air we breathe is nitrogen. And so and typically, 20% is enough to cause a significant amount of diffusion so that virtually all of the hemoglobin that are going by in those capillaries are able to be filled. In patients where that's not the case, you can assume that by Henry's law, if we increase that partial pressure, put them on 100% oxygen, and deliver it that way, that we're going to have more diffusion across. But once that oxygen passes and diffuses into the capillary, the hemoglobin molecules will undergo various biochemical transformations, dumping off hydrogen to allow oxygen to appropriately bind. And that way, oxygen can move through the lungs back to the heart and be pumped to the rest of the body. Ahmed, I don't know if you want to elaborate on kind of your thoughts on that process.
Yeah, I think this has sort of been an area of interest of mine ever since the last year of my undergrad. I was fortunate enough to take a 2-part cardiopulmonary physiology class. The first part being just, structure, function, etc. And then the second part looking at more extreme environments. And, on the note of, just the potential fibrosis or, inflammation of the lungs, right? Being aware of air pollution. That's something I completely took for granted, but you learn about particulate matter and how dangerous it can be, especially in, communities that have lower quality air, over time, just like the thought that stuff like that leads to COPD and things of that nature is, it's wild how something at the size of 2.5 microns can ruin your life, really. But at the level of the diffusion of diffusion of oxygen into the blood, you mentioned hemoglobin and point of it being saturated, and I think there's a couple of things that people need to understand. First of all, if you're healthy, more oxygen doesn't mean more saturation, because this curve is at 98% saturation in the average healthy human being that's not exercising currently. And a common question people ask is, well, where's the other 2%? I think that's just the thing with MCAT students, always, never appreciating the 98% on the test. Where did the 2% go? And so the answer to that is a couple of things. First, hemoglobin and oxyhemoglobin exist in a state of equilibrium. And so equilibrium by rule is never fully one way or another. It's somewhere in between the two extremes. The other thing is most of us, if not all of us listening to this podcast, live in an industrialized society. And what that means is from factories, from cars, etc., there's trace amounts of carbon monoxide in the atmosphere, which translates to trace amounts of carbon monoxide in our blood. And carbon monoxide is a very potent, we'll say, displacer of oxygen on hemoglobin. And so for that reason, we never get 100% saturation. But ultimately what ends up happening is at a PO2 partial pressure of oxygen north of about 90 to 100 millimeters of mercury, we're at full saturation essentially. And to give some context to this, Jayden mentioned how oxygen is roughly 20% of atmospheric pressure. Atmospheric pressure is about 760 millimeters of mercury. And so 20% of that is like 180, if I remember correctly, in that area. 145, 150, about 150. And so by the time that oxygen gets to the lungs, the PO2 is closer to 100 for a couple of reasons. First, we humidify air. So water vapor is being introduced into that air, which lowers the percentage of oxygen present. And there's also something known as dead space in the body, where there's non-ventilating regions of our airways, but we can get into that maybe in another episode. But yeah, ultimately what ends up happening is the lungs are at a very high PO2 and the tissues are at a much lower PO2 at about 35 to 40 millimeters of mercury. And so what ends up happening is if you imagine this S-shaped curve, I'm going backwards, this S-shaped curve, when you go to the lower end of that curve at the level of the tissues, the saturation drops. And that's a good thing because that means we're unloading oxygen. And Jayden mentioned how there's molecular conformational changes with hemoglobin involving protons. There's also an exercise component to it as well. But yeah, and then when we get back to the lungs, the PO2 is higher, so the saturation is higher. That means we bind more oxygen, and that just allows us to transport it to the rest of the body. And I think, it's important to understand that because there's a lot of, we'll say, bad science out there from we'll say like a marketing standpoint. Jayden, just out of curiosity, have you ever seen those like hypoxic masks that you see some people wearing on the treadmill while they're going, and it's meant to like simulate altitude?
I've seen that. I've seen it more on media and forms thereof, but not in person.
Right. And so funny enough, I saw someone wearing it at the gym and I couldn't help but laugh. And maybe Jayden, I'll defer to you here, but like, why is that funny for us? Like some people, and by no fault of their own, would see that, and a typical consumer could see something like that and say, that's a great idea. But why is it not?
Yeah, and this mainly just goes to carrying capacity. So hemoglobin carries like 98%. I mean, I'm just going to throw out that number. I don't know the exact. There is some equation out there that's useful for this, but the purpose of the equation is to teach us that hemoglobin carries almost all of the oxygen to our tissues. But as you pointed out, there's also an arterial non-bound oxygen pressure that is sitting in our vessels as well. And that's usually around 100, right? A hypoxemic patient might be 60 or less. If I'm totally blasting you or I with tons of oxygen, it's going to be higher than 100. I've seen it as high as like 400 or 500. That tells you should stop and back off the oxygen. But just because a patient, as long as the patient is saturated to that 98%, there's not much you're going to change with the oxygen mask or anything else to actually benefit and drive a hypoxemic response in exercise. So it's kind of a useless tool in that setting because you may, increase or try and increase or lower, tweak the arterial oxygen that's not bound, but that really has little difference at all with tissue perfusion and oxygenation. I'll throw it back to you as far as your thoughts on this, but I don't see any value to that.
Yeah, none at all. Like the idea of wearing a mask to simulate a hypoxic environment, for one, it takes more than a few minutes or an hour to elicit a hypoxic effect. And literature varies on this, but generally the consensus is you need to be spending at least 16 hours in the day at altitude to benefit from hypoxemia. And so wearing this mask is going to really, all it's going to do is it's going to strengthen your respiratory muscles because you have to work harder to inhale. But really, other than that, it's not going to do anything. And I think the other funny thing is whenever you're watching sports, guys throwing oxygen masks on. Typically, it tends to be football and like linemen, especially, and does nothing unless you're like. And there's no stadium, at least not in the NFL, that's at a high enough altitude where it becomes significant. Denver may be the only one remotely close, but like if you think about it, like we were talking about, when we exercise, our body produces metabolites that are generally acidic as byproducts. Those acidic metabolites cause what we call a right shift of the oxyhemoglobin saturation curve, which basically means at a given PO2, there's less saturation. Now, given the fact that this curve is sigmoidal, we're at the flat part of the curve in the lungs anyway, so shifting right doesn't really do anything. But at the tissues, we're in the sigmoidal part. So it actually becomes a significant difference in terms of unloading. But in any case, if we're at moderate altitude, it's not going to be enough of it. Like we were talking about, if you blast somebody with oxygen and you're already inhaling normal air anyway, you've already resaturated your blood. Like that oxygen mask isn't going to make it happen faster or more, thoroughly. It's, and this is a term that really helped me understand this. There's a difference between being perfusion limited versus diffusion limited. And, the difference between that is diffusion limited is you're not getting enough oxygen into your blood to, power whatever it is that you're doing. That is rarely the case for the average healthy person, even during exercise. Usually the limitation is perfusion. There's not enough blood moving into the lungs to carry all this oxygen away. And I think just having that understanding, number one, can help you not fall for scams on the internet. But two, I think from an MCAT standpoint, it's important because there's two factors in this, one being the respiratory system as far as diffusion goes, but then, the connectedness to the cardiovascular system and how they work together ultimately to move oxygen around. I think from an MCAT standpoint, the other big thing to discuss that we've kind of touched on briefly is the acid-base component. So Jayden, I'll throw it back to you. What are the big things for students to keep in mind from an acid-base standpoint and how it relates to ventilation?
So we have to remember that at least the big principles here, and that is the kidney and the lung work together to maintain acid-base status. Those are the two organs that contribute the most to ensuring that we don't become alkalemic or acidemic. And when patients become acidemic or alkalemic, lots of enzymes don't work properly. They don't think straight. They can become quite sick and essentially die if you become too much on either side of the spectrum. Big principle. And the kidneys and the lungs, they talk by ways of CO2 and bicarbonate. So kidneys are responsible for maintaining appropriate amount of bicarbonate to keep the pH around 7.4. The lungs are responsible to keep the CO2 levels at an appropriate amount to keep the pH at 7.4. Now, the reason I keep using this word appropriate is it depends on the context. If there's a kidney problem, and let's say the bicarb is really, really high, and that's more of an alkalemic setting, well, we have to then create more acid to balance that out. And we do that by slowing our respiratory rate, not breathing as deeply, to raise our levels of CO2, because we're not blowing off that CO2 as much by respiring, right? So this conversation back and forth from the lungs is really important. And when it becomes deranged, patients become very sick. Overnight, one of my gentlemen, he has a lung transplant, both sides. He's a very sick guy. He had a perforated colon, and he's in the surgical ICU for that. He has a bicarb of 22, which is on the lower end, right? That's an acidotic state. You would think that he would try and breathe off much more CO2, really lower that CO2 because CO2 is an acid, because we're already acidotic. And so I expected when I got an ABG or an arterial blood gas that his arterial oxygen or his CO2 would be low, somewhere in like the 30s or 20s to compensate. That wasn't the case. Because of his lung transplant and how bad his lungs are, it was at a 54. That was telling me he is working really, really hard to breathe and he's not able to compensate, right? And of course, his pH was like 7.2. He was getting very, very sick overnight. I had to essentially take over his breathing for him because his lungs were not doing the job. And I think those are the two big principles here, recognizing that bicarbonate is a buffer system. And you have to think of Le Chatelier's principle here, where we're pushing CO2 down plus water to create more bicarb or vice versa. And this game gets played back and forth, and we really need both organs to participate. So I'll throw it back to you, Ahmed, kind of more thoughts on this, but that's big picture.
Yeah, and I think you hit the nail on the head there, Jayden, the importance of that buffer system and how when we breathe in more, CO2 is blown off, right? Or sorry, when we breathe more rapidly, more CO2 is blown off. That system then shifts to make more CO2 and consume H+, which makes the blood a little bit more alkylemic. And so that's what happens when you go to altitude, actually. When you go to altitude, you start hyperventilating, your blood pH goes up. And then this is actually a really interesting, phenomenon, how your ventilation rate changes at altitude. And it has to do with the emphasis on CO2 that you mentioned. Not a lot of people recognize this, but the main gas that's regulated from a ventilation standpoint isn't oxygen, but it's carbon dioxide. And the body's more sensitive to changes in carbon dioxide. You mentioned your patient was at about 54. And so for context, about 45 to 50 is kind of normal, would you say, right, Jayden?
Yeah. Once you get above 50, you're really starting to see the effects. You and I would really start to like have a desire to breathe, right? If we were to go on into a pool and hold our breath and our CO2 rose to 50 or more, you and I are going to start to feel it for sure.
Yeah. Yeah. So probably closer to 45 or low 40s, that is sort of normal and baseline. Whereas oxygen, we're up around 100 millimeters of mercury in the lungs. But in any case, when we blow off too much CO2, our body senses less of it. There's less of a desire to breathe. And then our ventilation goes down. Okay. And then eventually it sort of levels off. And that's ultimately what actually causes altitude sickness is your ventilation adjusts before your blood and your pH specifically adjust. And so where people get altitude sickness isn't in the first 10 minutes or so of going to altitude, but like from the half an hour mark to about 2 days, because that's how long it takes the renal system, like we were talking about, to sort of adjust. And the reason I bring this up is it was kind of cool. I got to participate in a study at my lab where they were comparing two pharmaceutical agents and their effects on performance at altitude. And these, I had to be very strategic with when I participated in the study because these agents are diuretics. They make you pee, which gets them classified as masking agents. And so I could only participate in this study during an off season. Otherwise, I risk a failed drug test, but that's a story for another day. But yeah, basically these agents make you pee out bicarb, and it lowers your blood pH so that when you go to altitude, that sort of resets it to normal and then you're good. But the other thought, and this is sort of a closing thought for me about just visualizing how significant this buffer is. I mentioned those courses I took. One of them, we actually saw a video of a fighter jet pilot, and they're doing these tests on the pilot. And I'm trying to remember. I think it was a chamber, so it was a hypoxic chamber, and they gave him like a children's toy, like one of those ones where like you've got this circle and you put it in the circle peg and the triangle and the star, that kind of stuff. Like very, very simple toy. And so they gradually lowered the chamber's oxygen, and they were speaking to him like from the other side of the glass. And they're doing this test basically to assess how capable the pilots are of surviving in that environment. Because when you're flying a fighter jet, you're at significant altitudes and there's lots of G forces, etc. And the reason I bring this up is you mentioned how it can easily affect us once derailed. And this, brilliant PhD fighter pilot was now incapable of solving this children's toy simply because of the impairment caused by disturbances in that buffer. And to me, that's kind of crazy to think about.
I think anytime you see a patient who has altered mental status, always think about oxygenation and CO2.
Right.
If oxygenation is low, their saturations are in the 70s, they're not going to be able to think clearly. So you throw on an oxygen monitor to see what that looks like. The second thing is like, are they hypercarbic? Too much CO2. The other day, it was 3 a.m. I got a new admit to the SICU. A lady I was taking care of previously, she was unresponsive, completely comatose, and we were about to intubate her. I threw in her trach. I got a blood gas. Her CO2 was 90. You cannot function at that level.
No.
I put her back on the ventilator. I brought down her CO2. Within a few hours, she's talking to me and playing games. That's how serious, to your point, Ahmed, these levels have to be within a reasonable range for us to have success in daily functions of life. I wanted to close out by offering a little experiment for our listeners. Next time you're at a pool, I want you to go underwater and see how long you can hold your breath for and record that. Second time around, I want you to hyperventilate for about 30 seconds to a minute. Really bring down those CO2 levels low. And then do the same exact thing and see how long you can hold your breath for. I guarantee there's going to be a significant difference between the two. To Ahmed's point, our respiratory drive is almost always based on CO2 levels and not oxygen. Oxygen levels have to fall to about 40 before we start to have a drive to breathe. And that's why when I'm intubating somebody in the operating room, I have 4 minutes. There is no rush at all. I could stop your breathing right now and you'd have 4 minutes. If I pre-oxygenate you, I could keep you not breathing for 10 minutes. 10 minutes.
Yeah.
The reason we feel so short of breath when we go under a pool water is because of our CO2 levels rise acutely. So this, I think, is a tie-in to a lot of what Ahmed and I were talking about today. I think this is really important stuff. It's like the basis of being a doctor, is understanding respiratory physiology. I hope it was useful to everybody. And yeah, there's a lot of learning points from today's message, I think.
And I completely agree, Jayden. I think there's a lot of room for like self-directed learning with the respiratory system because there's so many applications. We talked about how it connects to renal, how it connects to cardiovascular. And by connecting to cardiovascular, it connects to everything else from musculoskeletal to digestive to simply because it's what's powering these systems. And it really does come down to a regulation of two gases driven by a buffer in our blood. And that's what allows us to function at a normal level and at an just to be able. And I think really from an MCAT standpoint, the main takeaways are the importance of that blood bicarbonate buffer and how that relates to ventilation, whether we hyperventilate or hypoventilate, how that's intertwined with renal regulation of pH, and then that oxyhemoglobin saturation curve. Why does oxygen bind at the lungs and unbind at the tissue? And, how can we regulate that in different conditions, like being at altitude, like exercising, or in the context of fetal hemoglobin as well. I hope you guys found the episode helpful, and we'll see you guys on the next episode of the Jack Westin MCAT podcast.
Bye, guys.